Hello, everyone. Thank you for joining us today. Today, we will be presenting on addressing health disparities for LGBTQIA+ people and people with HIV in public housing. This webinar is brought to you by the National Center for Health in Public Housing. Before we continue, this is just a kind reminder for all participants that you are muted upon entry. Please make sure that you engage in the chat if you have any questions, any comments, or any promising practices that you would like to share with us today as well. We also welcome you to provide your name, your title, what organization you're joining us from, or what state. Also raise your hand if you would like your line to be unmuted. This meeting is also being recorded, and the slides and the recording link will be sent to you via email as well. Okay, and the chat has now been enabled for everybody. Thank you so much. So the mission of the National Center for Health in Public Housing is to strengthen the capacity of public housing primary care grantees and other health center grantees by providing training and a range of technical assistance. NCHPH is a project supported by the Health Resources and Services Administration and is a national training and technical assistance partner that is 100% financed by this grant. The information presented today are those of the author only. So today, this is just a brief introduction of who will be presenting today. We will be having Dr. Jose Leon, who is our Chief Medical Officer at NCHPH, and myself, that I will be helping moderate and facilitate today's webinar. I am the Manager of Training and Technical Assistance, and my name is Fide Pineda Sandoval. We also have our guest speaker from Fenway Health. He is Dr. Sean Cahill, the Director of Health Policy and Research. So now we're going to be discussing some background information about health centers that are close to public housing. According to HRSA's UDS data in 2022, there were over 1,300 federally qualified health centers that served to 30.5 million patients, 483 FQHCs that were immediately accessible to public housing that served to 6.1 million patients, and 107 were public housing primary care grantees that provided services to over 935,000 patients. The interactive map to the right depicts the health centers that are immediately accessible to public housing and can be accessed through our website at nchph.org. And here we have some information that describes the demographics of residents of public housing. As it is displayed, the 1.5 million residents demonstrates the characteristics that differentiate residents of public housing from the general US population. For example, residents of public housing are 52% white, 43% African American, 26% Latinx, 19% are elderly, and 36% are children. Residents of public housing are also disproportionately from households that are low income and female-headed. And now I will transfer this information to Dr. Jose Leon, who will be providing some background information about HIV in health centers.
Thank you, Fide, and good afternoon, everyone, or good morning, depending on where you are in the country. It's a great pleasure to be part of this conversation and to hear from Dr. Cahill about HIV and the LGBTQIA+ community. Before we get into the nitty-gritty of the presentation, we are just going to provide some basic information or basic data on the health centers serving public housing residents. And if you are familiar with the Uniform Data System, there are several measures that health centers need to report. And one of them is the number of patients with HIV diagnosis. So in 2022, the latest data that we have available for all health centers, the number was almost 200,000. And for those, the 107 public housing primary care grantees, they reported to have almost 5,000 patients with an HIV diagnosis. Next slide, please. The quality of measure that health centers need to report, and this is for all health center for the 1,300 plus health centers. The number of patients who have been diagnosed for the first time with HIV in 2022 were 7,000 or over 7,000. And the estimated number of patients seen within 30 days of first diagnosis they were about 5,000, 6,000 approximately. And the estimated percentage of patients seen with 30 days of first diagnosis of HIV was 82%. Next slide, please. In regards to the quality of care measures, the patients who have been screened or who were screened in 2022, patients between the ages of 15 and 65 were 16,333,000. Of these, that's the total number of the population. 7 million patients were tested, or over 7 million patients were tested for HIV. And the estimated percent of a patient tested for us well was the percentage was almost 44%. Next slide, please. This is a really good opportunity to discuss a little bit about the ending the HIV epidemic by 2030. The HHS goal is to reduce the new HIV infections in the United States by 75% in 2025 and by 90% in 2030. And we are trying to advance health equity and scaling up key HIV prevention and treatment strategies. Health centers are doing all they can and providing different strategies and promising practices. They are assessing patients who are at risk. They are screening patients. They are providing pre-exposure and post-exposure prophylaxis and other strategies to try to reduce the incidence and prevalence, the incidence of HIV in their communities. Next slide, please. In regards to sexual orientation data, this is the data provided by the public housing primary care grantees. As a reminder, we are talking about 107 health centers, and the percentage of patients who reported to be either lesbian or gay was 1.88%. At the heterosexual population was over 95%. 2% identify as bisexual, almost 1% as other, don't know as over 2%, and there was a very decent percentage on those who chose not to disclose, almost 5%, and this is very important as well. We need to make sure that we get some information in regards to those who are trying to not to disclose, regardless of their sexual orientation. We can assess whether or not these patients are at risk and follow the Centers for Disease Control Control and Prevention recommendation on HIV screening. Next slide, please. In regards to gender identity, public housing primary care grantees reported that almost 40% were of the patients that they tested were men. Female patients were about over 60%. 0.19% identify as transgender men or transgender male or transmasculine. 0.24% reported to be transgender woman, transgender female, or transfeminine. Other 0.63%. Again, we have a percentage who chose not to disclose, over 1%. and unknown 32 or over 32%. Again, the same recommendations. We need to make sure that we are screening patients who are at risk and follow the Centers for Disease Control and Prevention screening, HIV screening recommendations. Next slide, please. Fide, I can turn it over to you.
Yes, thank you so much. So now we will transfer the presentation to Dr. Sean Cahill.
Great. Hi, everyone. Thank you very much, Fide and Dr. Leon. Let's see here. So are you able to see my slides okay, hopefully?
We just need to put it on full screen.
Yeah. Okay, great.
Perfect. Thank you.
Okay, so yeah, so I'm going to talk about the same topic, which is some different detail. So let me just shrink this. Okay. So as Fide mentioned, I'm the Director of Health Policy Research at the Fenway Institute, and we are a research institution that's nested within a federally qualified health center and HIV clinic here in Boston, Massachusetts. I have academic appointments at Boston University School of Public Health and Northeastern University School of Health Sciences. And I also serve on the Massachusetts Special Legislative Commission on LGBT aging. So I'm going to talk a bit about disparities affecting LGBTQIA plus populations, including behavioral health disparities, as well as people living with HIV. Then talk a bit about the impact of discrimination on health and how experiences of discrimination can function as a barrier to accessing healthcare. I'm then going to talk a bit about some of the research that looks at the relationship between being homeless or being unstably housed and how that affects people's health, particularly for LGBTQ plus people and people living with HIV. And then talk about the importance of non-discrimination laws and policies, including housing non-discrimination and non-discrimination regulations that govern access to healthcare, which are considered public accommodations. So LGBTQ people experience higher rates of cardiovascular disease, diabetes, and obesity. I'm just going to try to hide floating meeting controls. Yes. Okay. So we see high rates of cardiovascular disease, diabetes, and obesity in our populations. Among LGBT people, we see high rates of risk factors for cardiovascular disease, such as smoking, lifetime depression diagnosis, mental distress. We see higher rates of myocardial infarction, which is just a fancy way of saying heart attack among transgender people, as well as risk factors for cardiovascular disease among transgender people. We see higher rates of diabetes among both sexual minority women and sexual minority men, lesbian and bisexual women, gay and bisexual men. And we also see earlier onset of type 2 diabetes, which is the most common form of diabetes that people in the United States have. And we also see higher rates of obesity among sexual minority women. In addition, there are higher cancer risk factors in sexual and gender minority populations, including tobacco and substance use, behavioral health burden, as well as nulliparity. And nulliparity just means that you have never given birth. So while many lesbian and bisexual women do give birth, as a group, they are less likely than heterosexual women to give birth. And this is a risk factor for breast and ovarian cancer. The tobacco industry has historically targeted the LGBTQ plus community with advertisements. And this is one of the reasons why we see higher rates of tobacco use in our communities. So this is from the Truth Initiative, which is the tobacco settlement project funded by the settlement with the tobacco companies in the 1990s. And they talk about, they show two ads that ran in magazines. The one on the left ran in mainstream magazines. The one on the right ran in LGBT publications like The Advocate, and was obviously aimed at gay men versus a more general audience. These are some other ads that ran. The one on the left talks about freedom to marry, as well as freedom to inhale, sort of drawing a parallel between equal rights for LGBT people and the right to smoke. And then the ad on the right is a gender diverse person vaping. So we, in addition to combustible cigarette use and higher rates of that in our communities, we also see higher rates of vaping. So here's some more data from the Truth Initiative, funded by the settlement with the tobacco companies, showing that lesbian, gay, and bisexual adults are between 30% and 40% more likely to smoke than straight adults. So men about 40% more likely, women about 30% more likely. We also see higher rates among transgender youth, higher rates of smokeless tobacco use, combustible cigarette use, and e-cigarette use, 3 to 4 times the rates. And then here's some data looking at the increase just over 1 year of e-cigarette use among youth and young adults by sexual orientation, showing a higher burden of vaping in sexual minority young adults. We also see lower rates of preventive cancer screenings in LGBT populations. So lower rates of breast cancer screening among lesbian and bisexual women. That disparity also intersects with racial ethnic disparities, where we see Black women and Latina women less likely to be screened for breast cancer and for cervical cancer. There are lower rates of cervical cancer screening among lesbian and bisexual women and transgender men. And then we see higher rates of human papillomavirus related anal cancer in gay and bisexual men and transgender women. And you can get vaccinated against HPV, and that dramatically lowers your risk of getting anal cancer and other forms of cancer of the throat and head and neck. But only a small minority of people are vaccinated. So it's really important that these are generally youth vaccinations now for young people. And it's really important that people to be vaccinated, particularly gay and bisexual males and transgender women. So now I'm going to talk a bit about some disparities in behavioral health, particularly substance use. And these come from an analysis of about a 35-state sample published a few years ago in the Journal of Community Health. This is the Behavioral Risk Factor Surveillance System survey. And almost all states do this survey. And in any given year, between 30 and 35 states ask sexual orientation and gender identity questions and allow us to slice and dice the data and look at LGBT people versus straight and cisgender people. So what this analysis found is that lesbians were more likely to binge drink and to currently smoke, about 1.5 times as likely to binge drink, almost twice as likely to smoke. Bisexual women also had nearly twice the rate of binge drinking and smoking. Gay and bisexual men were more likely to smoke, although the disparity for bisexual men was not as great as it was for gay men. And then we did see also higher rates of mental distress and depression among bisexual men and women, about 2 to 3 times the rate, particularly for bisexual women. The Youth Risk Behavior Survey is another place where we see higher rates of substance use among sexual minority people. So these are surveys that most states do, and an increasing number of them are asking sexual orientation and gender identity questions, which allow us to document substance use disparities in our communities. So YRBS data that was analyzed by the Centers for Disease Control and published in Morbidity and Mortality Weekly Report found disproportionate substance use among high school age gay and bisexual males, higher rates of injection drug use, about 5 times the rate, about 8 times the rate of heroin use, 4 times the rate of cocaine use, and also much higher rates of methamphetamine use, crystal meth use, among men who have sex with men versus males who reported only sex with female partners. Another analysis of transgender Medicare beneficiaries looking at electronic health records data found that transgender Medicare beneficiaries were more likely than cisgender or non-transgender beneficiaries to have substance use disorder in their electronic health record. And another sort of meta-analysis of crystal meth use among gay and bisexual men found that MSM, or men who have sex with men, have been shown to be about 20 times as likely to use crystal meth, with an estimated 10 to 25% of MSM, depending on the study, reporting crystal meth use in the context of sexual behavior in the past 6 months. This is a very important health disparity. Crystal meth use has significant health impacts, but it also increases your risk of contracting HIV, syphilis, and other STIs. An analysis of National Survey of Drug Use and Health data led by Megan Schuler of the RAND Corporation. This is a survey that SAMHSA does, the Substance Abuse and Mental Health Services Agency, found really for the first time higher rates of opioid use among sexual minority people. So all lesbian, gay, and bisexual subgroups had elevated lifetime pain reliever misuse compared to heterosexuals who are in the same gender categories as men, women. Also higher rates of injection heroin use and lifetime heroin use, as well as opioid use disorder and opioid misuse. We also see, and this I know is an important issue in cities and in urban areas, we see higher rates of asthma in those areas geographically, but also among LGBT people compared to heterosexual people. So higher rates of lifetime asthma diagnosis and just higher asthma rates among older lesbian and bisexual women compared to heterosexual women. Another important behavioral health issue is depression. And these are some data from the Massachusetts Behavioral Risk Factor Survey. We worked with public health department staff here and analyzed differences between older people who are heterosexual and cisgender versus older people who are LGBT. And we found about 60% higher prevalence of diagnosis with depression among LGBT older adults compared to the general population of older adults. And this is something we see in other states and around the country. So here's some more data on depression. This is also an important issue with older gay and bisexual men who are living with HIV. Many older people with HIV, and in the US, about 2/3 of older people living with HIV and people with HIV in general are gay and bisexual men and transgender women. We definitely see high rates of loneliness, social isolation, and lack of social support with these populations. And so it's very important that we develop interventions that help increase people's social support networks and reduce their social isolation. That can help reduce loneliness and depression, which are significant health risks. So depression is now a leading cause of morbidity and mortality among older people living with HIV, exceeding even that caused by HIV itself. And untreated depression correlates with poorer health outcomes among older people living with HIV. It's also important to understand that a lot of these behavioral health disparities that I'm mentioning, depression, social anxiety, substance use, a lot of them are related to experiencing depression and, experiencing discrimination and stigma. So we did a study of about 550 transgender adults in Massachusetts and Rhode Island, and we did a survey right after we had an anti-transgender ballot campaign here in Massachusetts, which the voters rejected by about a 2-to-1 margin, and it would have reversed. We got a law passed through our state legislature that prohibited discrimination in public accommodations, including health care for transgender people in Massachusetts. But anti-transgender activists got it put up on the ballot for a vote, and thankfully the voters rejected repealing the non-discrimination ordinance. But in the process of trying to repeal that law, they put out a lot of anti-transgender advertisements, and there was a lot of anti-transgender discourse, including claims that transgender people, transgender women using public restrooms were a threat to the safety of other people. And so we asked people if they saw those ads, and if so, if they heard some of those claims about transgender people, which were not backed up by any research or crime statistics or anything like that. And what we found is that those people who said that they had seen negative images of transgender people in the media had higher rates of depression, anxiety, post-traumatic stress disorder, and global psychological distress. So we saw about 18% higher rates of depression, about 26% higher rates of anxiety, 25% and 28% higher rates of PTSD and global psychological distress. So these disparities that we are talking about mostly focus on LGBTQIA plus people. They also intersect with racial and ethnic and other disparities. So we know that in HIV, in the United States, we see, and in other countries in Canada and Europe, we see higher rates of burden on the Black community. Also in the United States, we see higher rates of burden on Hispanic or Latinx people. In particular, Black and Hispanic men who have sex with men and transgender women bear a higher per capita burden of HIV. We also see higher higher rates of ovarian breast, or poorer outcomes, I should say, with ovarian, breast, and cervical cancer. Sexual minority women don't necessarily have higher rates of ovarian, breast, and cervical cancer, but they tend to get diagnosed later and have poorer treatment outcomes. Why? Because they're less likely to get screened for these very important health conditions. And then we also know that rural LGBT people are less likely to disclose that they are LGBT to a healthcare provider, and that can put them at risk for STIs and other health conditions. If they don't tell their provider that they're a man having sex with another man, then their healthcare provider may not offer them an HIV test or tell them about pre-exposure prophylaxis for HIV prevention, or talk to them about Mpox or some other important health issue that's happening. So this is a good example of a health condition where we see disparities along sexual orientation as well as racial ethnic difference. So gonorrhea, everyone is at risk of gonorrhea, but as you look at this graphic here, it shows us that men are at greater risk than women, but also men who have sex with men, the sort of burgundy or maroon color on the left, have the greatest percentage risk compared to men who have sex with women only. In other words, heterosexual men, which are the light blue color. And then women are the black bar all the way over to the right, have the lowest percentage risk. So greater risk for men versus women, greater risk for MSM versus men who have sex with women only. And then we also see racial and ethnic disparities in gonorrhea prevalence in the United States. So we see among males and females a higher rate of gonorrhea on a per capita basis among Black or African American individuals, and then also higher rates among American Indian and Alaska Native and Native Hawaiian and Pacific Islander individuals. Discrimination is also an important factor in these health disparities that we see. And so discrimination hurts health and well-being, as well as serves as a barrier to accessing care. More than 1 in 3 LGBTQ Americans face discrimination in the last year, according to a Center for American Progress study. And we see higher rates among transgender people and among people of color who are LGBTQ. 15% of LGBTQ Americans who experience discrimination reported postponing or avoiding medical treatment because of that experience with discrimination. And we saw about twice the rate among transgender people. About 2/3 of people said that the discrimination they experienced affected their psychological well-being, and nearly half said that it affected their physical well-being. Racial stigma is also an important issue affecting LGBTQ plus people of color. So this is a major barrier to care for Black, lesbian, and bisexual women. Anti-Black stigma is common in predominantly white LGBT settings. And there's a long history of structural stigma and discrimination against Black people in healthcare settings that contributes to medical mistrust. And this acts as a major barrier to accessing care for Black LGBT people. And I'll provide some data specific to COVID-19 vaccination and Mpox in a little bit, showing that. So, I think a lot of you know this already, but it's just important to call out that intersectional and layered experiences of discrimination are experienced in our communities, as well as economic marginalization. So, people are LGBTQ and they're female and they're members of racial and ethnic minority groups, and they may be immigrants, and they can experience stigma and vulnerability based on those multiple identities. On the right here is just a report that's on our website where we surveyed LGBTQ youth of color in the greater Boston area and asked them a lot of questions about their lives. One of the things we asked was, on what basis do you experience or have you experienced discrimination? And what we found is that the most common form of discrimination that people had experienced was racial ethnic discrimination, about 45%. And then that was closely followed by discrimination based on their sexual orientation and gender identity, and then other demographic characteristics. This is a graphic from a paper that just shows that Black sexual minority men, in other words, gay and bisexual men, are more likely to experience racial and ethnic stigma in LGBT spaces than they are to experience anti-LGBT stigma in their, in many cases, predominantly Black neighborhoods of residence. So this was true. So Black gay and bisexual men experienced more racism than anti-gay or bisexual prejudice, but Asian, Latino, and white sexual minority men were more likely to experience anti-LGBT stigma or prejudice versus stigma based on their racial or ethnic identity. We also know that because of these dynamics that I'm describing, sexual minority women and transgender people are less likely to access routine preventive health care compared to their straight and cisgender peers. Another important issue, and another way that discrimination sort of impacts people is through medical mistrust. So due to stigma and healthcare discrimination, many people in our communities, particularly people of color and transgender people, experience medical mistrust. And this could affect the likelihood that they will know, for example, if there's a new health condition like COVID-19, this might affect whether they know if a vaccine is available, how to access that vaccine, and be willing to trust those offering the vaccine. If you don't have a primary care provider, if you're not in sort of routine preventive health care, you may not have somebody you can ask about an emerging health threat like COVID-19 or Mpox. Many older people also experience medical mistrust. So people who are now in their 70s and 80s or even 60s, when they were younger, the medical establishment pathologized same-sex behavior and gender diversity. Many were subjected to shock therapy, even lobotomies. Some were committed to psychiatric institutions without their consent, and this was done with the support of mainstream medicine. So just to give you an example of how much the world has changed in the last 51 years, this is a panel at the American Psychiatric Association conference in 1972, and the person on the right is Dr. John Fryer, who was a gay psychiatrist, and then the people on the left are gay rights activists, Barbara Giddings and Frank Kameny, and they were advocating for the APA to remove homosexuality from the DSM, the Diagnostic and Statistical Manual, where it was considered a mental disorder, a mental health disorder. And but Dr. Fryer was worried that he would lose his license to practice as a psychiatrist if he made this case publicly and disclosed his identity. So he wanted to do this anonymously, and that's why he has this kind of strange looking mask on. And also he wore this like oversized tuxedo for some reason. But thankfully the APA did delist homosexuality the following year, so this effort was successful. And then this is something from 60 years ago, actually the year I was born. On the front page of the New York Times, there was an article called "Growth of Overt Homosexuality in City Provokes Wide Concern." And if you read this article, which I have my students read when I teach classes on LGBT public policy issues, it's really fascinating. You'll learn that the medical establishment, the law enforcement establishment, and religious leaders were all in consensus that homosexuality was a problem that had to be controlled, that had to be suppressed, that had to be treated and cured. And so that's just how much our country and our culture have changed. So for older people, this is what they were taught and raised to believe, and that affects the way they think of the healthcare establishment today. Intersex people often have challenging relationships with the healthcare system, and many have experienced medical trauma related to medically unnecessary surgeries conducted without their consent, as well as unnecessary and kind of voyeuristic medical examinations. So we do see higher rates of medical mistrust in these communities: intersex people, transgender people, people of color, and older people in our communities. And so this is some data from related to COVID-19 and Mpox, showing that these two recent health kind of emergencies exacerbated medical mistrust. Black LGBT people, especially Black lesbian and bisexual women, were much less likely to be vaccinated for COVID-19, according to the CDC's Morbidity and Mortality Weekly Report. And we also saw significant Mpox vaccine hesitancy among Black and Latino gay and bisexual men. So this graphic here shows that on a per capita basis, rates per 100,000 individuals, we saw higher rates of Mpox among Black people and among Native Hawaiian and other Pacific Islanders in the United States, much lower rates among white, Asian, and American Indian, Alaska Native populations, and higher rates among Hispanics as well. And part of the reason why we saw these higher rates was because people were less likely to get vaccinated, or they had a harder time accessing vaccine, even though vaccines were available. But it wasn't easy in the early months of the Mpox outbreak to access that vaccine. Okay, another important factor in our community is poverty. We see higher rates of poverty among LGBT people, particularly people of color, bisexual women, and transgender people. We also see higher rates of poverty among rural LGBT people, as well as urban LGBT people, compared to heterosexuals. And then a convenience sample of transgender people, a very large convenience sample, about 28,000 respondents, found about twice the rates of poverty, about 3 times the rate of unemployment, and very high rates of lifetime homelessness and homelessness within the past year among transgender people in the United States. We also know that LGBTQ youth are much more likely to be homeless at some point in their lives. Close to a third of LGBTQ youth, according to the Trevor Project, have experienced homelessness or housing instability. And housing insecure youth who are LGBTQ report about 2 to 4 times the rates of depression, anxiety, self-harm, and suicidality, either considering or attempting suicide, compared to those who did not report any housing instability. Poverty also affects health insurance coverage, which affects access to healthcare itself. So lesbian and gay women were less likely to have health insurance and were less likely to have a usual primary care provider, according to the National Health Interview Survey. And these differences were statistically significant. We also see racial and ethnic differences in health insurance coverage. with whites and Asians having the lowest rates of uninsurance, American Indian Alaska Natives having the highest rates of uninsurance, closely followed by Hispanic and Native Hawaiian and other Pacific Islander individuals, and then Black Americans are kind of in the middle. So certainly compared to white Americans, Black Americans have higher rates of uninsurance, even though for all groups, the picture has improved since the implementation of the Affordable Care Act, but those racial and ethnic disparities have not gone away, unfortunately. Here's a little data from an analysis we did here in Massachusetts, looking at BRFSS data for older adults who are LGBT versus straight and cisgender. What we found is that older LGBT people had higher rates of fair or poor overall health. They were nearly twice as likely to report ever having been diagnosed with a depressive disorder. They were about as likely to be a veteran and have children in the household as the general population, but they were more likely to rent than own their own home. So we've seen rents shoot up in the last 3 years all over the country, including here, and this is disproportionately affecting the LGBT community. LGBT people also said that they were more likely to report having difficulty paying for housing or food in the last year. They were twice as likely to fall and be injured. They had 4 times the rates of suicidal thoughts, 3 times the rates of lifetime sexual violence victimization, and we again saw higher rates of overweight and obesity among sexual minority women. So a little bit about housing disparities. We see higher, actually lower rates of home ownership by LGBT identity and by transgender status. So members of our community are less likely to own their homes, more likely to rent, which increases vulnerability to, the crazy housing market we're all dealing with right now. We also see lower home ownership and greater mortgage debt among the LGBT community. So these are data comparing same-sex couples and heterosexual or different sex couples, lower rates of home ownership among same-sex couples, and higher rates of mortgage debt. We also see, like I said, higher rates of homelessness, but people experience discrimination in homeless services as well as in housing and mortgage lending. So like I said, LGBT youth are 2 to 4 times as likely to be homeless as other youth. Family rejection is a major driver of higher homelessness rates among youth. But studies with same-sex couples have found that same-sex couples are less likely to get called back for an apartment that's for rent. They get charged more in rent, and they also get charged higher interest rates for mortgages if they're able to get a mortgage. Among older adults, LGBT people are more likely to be turned away or charged higher rents at assisted living centers compared to straight cisgender people, also at nursing homes, and they often experience discriminatory care and neglect in those long-term care settings. Housing instability correlates with greater likelihood of chronic disease. So a study of transgender veterans in the VA system across the US found that experiencing housing instability makes you more likely to have mood disorder, PTSD, alcohol abuse disorder, illicit drug abuse disorder, in other words, illegal drug use disorder, tobacco use, suicidality, and hepatitis C. A study of transgender people in South Florida found that unstable housing was significantly associated with not getting screened for HIV for transgender people, while being stably housed correlated to engagement in routine care that often includes HIV and STI screening. People who are unstably housed or homeless are more likely to have HIV as well as other health conditions. And in any given year, close to 20% of people living with HIV in the United States are unstably housed or homeless. Housing helps people living with HIV adhere to their antiretroviral medications and successfully treat the disease. And unstably housed people with HIV are less likely to be virally suppressed. So this was a study of people with HIV living in Washington, D.C., and it found that those who, of about 9,000 people with HIV, those who are unstably housed were significantly less likely to be virally suppressed. Only about 60% is likely to be virally suppressed, and they were significantly more likely to have a substance use or mental health disorder. Another study looking at a population of HIV positive individuals found that being homeless and being unstably housed increased emergency department use, urgent care use, and hospitalization. So those who were unstably housed had about a 35% higher rate of urgent care visits, about twice the rate of emergency department visits, and almost twice the rate of hospitalizations. Those who were homeless or unhoused had about twice the rate of urgent care visits, 4 times the rate of emergency department visits, and about 3 times the rate of being hospitalized. These are all very costly activities, and the healthcare system is trying to reduce ED visits and hospitalizations and trying to catch problems before they reach a crisis point. So housing and ensuring that people have the housing they need could significantly improve these costly healthcare practices. So I'm just going to finish by talking about non-discrimination laws. We have federal non-discrimination regulations right now. They were put in place about 10 years ago. They were repealed by the last administration. They've been reinstated by the current administration. Also partly due to a Supreme Court ruling in 2020 called Bostock versus Clayton County, Georgia, which very importantly said that if you discriminate against somebody because they're homosexual or transgender, you are discriminated against them based on their sex. It's a very important decision, and because the Affordable Care Act references the 1964 Civil Rights Act, which has sex discrimination in it in Title VII, this court ruling is significant beyond just employment. So there's a significant need for non-discrimination in healthcare and housing. Only about 20 states in the United States prohibit sexual orientation and gender identity discrimination. The dark states here in the North and West Coast and Rocky Mountain states and Hawaii. But the current administration has said that it will interpret the Affordable Care Act's non-discrimination provisions, Section 1557, which prohibits sex discrimination, to include sexual orientation and gender identity, consistent with that Supreme Court ruling in Bostock versus Clayton County, Georgia. It's also important, though, that we get the Equality Act passed. This law would prohibit discrimination on the basis of sexual orientation and gender identity in employment, housing, and public accommodations. About 4 out of 5 Americans support such a law, but unfortunately it's stuck in Congress and probably won't pass this session. This law was first introduced in 1974 by Congresswoman Bella Abzug of New York City. So it's been 49 years since Congress first considered prohibiting anti-gay discrimination. And unfortunately, it hasn't taken action, but we hope to see that happen sometime in the near future. And I'll just finish with a quote from President Biden's executive order on the day he was inaugurated. He said, "People should be able to access health care and secure a roof over their heads without being subjected to sex discrimination. All persons should receive equal treatment under the law, no matter their gender identity or sexual orientation." And then he called on all of the federal agencies to basically take steps to enforce this Supreme Court ruling and prohibit sex discrimination, including SOGI discrimination. The Housing and Urban Development Organization has a lot of policies related to SOGI discrimination, including a rule they promulgated 11 years ago. And there's a lot on their website, a lot of materials. They interpret sex discrimination to prohibit SOGI discrimination. And if you think you've experienced discrimination in housing based on SOGI, contact your local HUD office or the phone number here. And there's also materials on the HUD website. If you just Google HUD and anti-LGBT discrimination or SOGI, you will find these materials here. And you can get help with your case. So thank you very much. I'm going to hand it back now to Fide.
Yeah. Thank you so much, Dr. Sean Cahill. This was a lot of information. It was great to learn about all the disparities that this population experiences. So now I'm going to share my screen. Okay. So now I just would like to just remind everybody that we have our next upcoming sessions in December 8th at noon. And our last session will be in December 15th. And now we will go on to our Q&A session. So if you have any questions that you would like to ask Dr. Cahill or Dr. Jose Leon regarding HIV disparities among LGBTQIA plus the population, please let us know in the chat.
Either just a quick reminder for those who have already registered and want to attend the other two sessions, they don't have to register again.
No, no.
So just if you have this link, you can use exactly the same link for the upcoming.
That is correct.
And I see a couple of questions, Fide, specifically is regarding the UDS data, the percentage is greater than 100%, right? And that is correct. One of the issues that we see when we analyze UDS data is that some health centers are reporting patients who are under the age of 18, even though that's not required. Health centers collecting this information through their electronic health records can also send that information to HRSA. That's the reason why you see that some numbers are over, or some percentages are over 100%. And in regards to the unknown information, that is related to the electronic health records as well. If there are some health centers that are not obtaining this information from patients because the question is not embedded into the electronic health records. So when they have patients and they don't have any way to collect that information, they use the unknown category. And the other reason why there is an unknown category is that some patients leave the question blank. They do not say that they do not want to answer the question, but instead of doing that, they leave it blank. So if that's the case, the recommendation for the health centers is to report those as unknown. For the next two sessions, we are going to hear from two health centers. They are going to provide some information about their programs, their HIV programs, the efforts that they are making to address the issues and the health inequities and the social determinants of health affecting LGBTQIA plus and those living in public housing as well. If you have any questions, again, please feel free to either use the Q&A box or the chat box. Type your question, or if you want your line to be unmuted, well, Fide can also use the raise hand icon and Fide can unmute your line.
So in the meantime, while we wait for some questions to come in, I'd like to also remind everybody to please complete our post-evaluation survey. And in the post-evaluation survey, you will see a question at the end that states whether you would like to get a CME certificate. So if you're interested, let us know. And then that way we can work with Fenway Health to provide those certificates for you.
If you are also interested in additional data, we recommend, specifically regarding public housing residents, the Centers for Disease Control and Prevention and the U.S. Department of Housing and Urban Development have developed a report. The name of this document is Health Picture of HUD-Assisted Adults, where you can find information on the chronic medical conditions affecting those living in public housing and those receiving assistance from HUD as well. So that's another document that you can find on HUD's website. And there is also a link from our website, the National Center for Health in Public Housing, www.nchph.org. And Sean, since we don't have any questions, I'm gonna ask you one quick question.
Sure. Yeah.
And this is related to the data that you showed. In your experience, and you've been analyzing data for many years, do you see a progress on addressing and tackling the issues affecting the LGBTQIA plus population? And
Yeah, absolutely. Absolutely. I mean, the amount of attention that these health disparities are getting from the current administration, the Department of Health and Human Services, is really phenomenal. There's a lot of great work happening at the state level in many states around the country, and also in health professional associations like the American Medical Association, the American College of Physicians, lots of different professional associations. American Academy of Medical Colleges are doing really great work in terms of education and training, and training their members to do a better job of providing care. And a lot of what I talked about are their health disparities, and you could interpret that in a negative way, but I think understanding what the disparities are is the first step toward addressing and reducing and hopefully eliminating them. So I think just a lot of this research is kind of recent, like 10, 20 years ago, we weren't necessarily asking sexual orientation and gender identity questions. And now more and more they are, like the state Medicaid forms are starting to ask sexual orientation and gender identity questions on Medicaid enrollment forms, which is a huge development. And the health centers since 2016, like you mentioned, have been asking health centers to report de-identified SOGI data on their patients. So that's really allowing us to better understand these disparities and to address them. But, like we have HIV disproportionately affects gay and bisexual men, transgender women, but the vast majority of people in our community don't get HIV. Also, we have many thousands of people who are on PrEP for HIV prevention. So we have these new biomedical interventions which can help people not get infected with HIV. Another new development is DoxyPrep, which I'm sure you'll be working on rolling out if you're not already doing it. This is taking doxycycline as post-exposure prophylaxis after a sexual encounter to dramatically reduce your risk of getting syphilis, gonorrhea, or chlamydia. That's another intervention that's now in the toolbox that we can use to try to reduce the number of STIs that people are getting. So there's a lot of great things happening, and if we use them judiciously, I think we can improve the health picture for the LGBT community and other communities as well.
Excellent. That's a great response, and we are very pleased to hear all the progress and efforts being done by different organizations. So thank you so much for that, Sharon. It is about time, so I don't see any other questions.
All right,
So-
well, thank you everybody for joining us today. Thank you, Dr. Sean Cahill, for the great information you shared with us, and Dr. Leon as well. One final reminder to please complete our post-evaluation survey. And here is our contact information. If you have any follow-up questions, you may contact Dr. Leon at jose.leon@nemgt.com or me at fide@nemgt.com. Thank you, everyone, and have a great rest of your day.
Thank you.
Thank you.